A very warm good evening to all of you who have joined us live from the different parts of India today in this meeting. I welcome you all to this meeting, which will discuss the newer paradigms of management of type 2 diabetes. It is with great pleasure that I welcome you to this international scientific expert meeting. And we have gathered here today to discuss the recent discovery, collaboration, and innovation that has transcended borders. And we can see we have faculty from different parts of the globe today that will unite the mind to share their patient technology and knowledge that has been brought together over the last 2 years in the management of the patients with type 2 diabetes. This meeting represents the convergence of the ideas and the data of the usage of this new molecule that has been available over the last 2 years, and to discuss more into the holistic management for the patients with type 2 diabetes. We have four experts from diverse parts of the India, and also one of them has joined us from Singapore with their unique contributions to the medical research, and they will be sharing their experience with us today. So to begin with, we are extremely privileged to have Dr. Sanjay Karla sir as the chairperson for the meeting. Sir needs no introduction. He is a consultant and head Bharti Research Institute of Diabetes and Endocrinology. He comes from Karnal, a beautiful city in northern part of the India. He has been a past president for the Endocrine Society of India, a president-elect for the South Asian Federation of Endocrine Societies, a board member and chairperson, an education working group for the International Society of Endocrinology, president for the Indian Professional Association for Transgender Health, a section editor for various textbook of medicines, Endotext, and the PubMed Index textbooks. His hobbies includes traditional Haryani Mudgar and Bhangra. I welcome you, sir, once again, and Dr. Unni, Dr. Nitin, and Dr. Lim to this meeting. And to take it forward from here, I would request Dr. Sanjay Karla, sir, to take it over from here. Over to you, sir.
Thank you, Dr. Kingshuk, and warm greetings to everybody who is logged in today. Now, the world is changing, and it's changing very fast. We see that around us, whether it's about the way we live, the way we communicate with each other. This is one example of change. We are able to communicate now with our expert speakers from across India and Singapore through this wonderful medium. We are also able to communicate with you, and we are able to share best experiences. We are able to learn from each other. This is what change means. But there are other changes that are occurring. Next slide, please. One of the changes that we see is next slide, please, is in the definition of humankind, the definition of mankind, womankind. Did you know, any of you, did you know that in the past 14 years, India has had to change, not once, but twice. Twice we have had to change the definition of the Indian reference man and the Indian reference woman. We've increased the weight of the Indian reference man by 10 kg over the past 1.5 decades. And this is twice in the past 15 years. So which means that if we end up changing the name of our great and beautiful country once in 75, 80 years, it's not too much of a deal. We shouldn't read too much into that. Another thing that is changing and is going northwards is the weight of the nation. I remember authoring an article with Dr. Unni Krishnan more than a decade ago, the weight of the nation. Little did we know at that time that that is going to get us so many citations that RH index, RI index has gone up markedly because of that single article. It's such a heavyweight article. And that reminds me that we need to write a new article now on the weight of Asia, the weight of the continent with Dr. Vivian Lim and Dr. Nitin Kapoor, because our data is outdated now. But what has happened is that across India, the number of people living with diabetes is going up. The number of people living with pre-diabetes is going up even faster. There are a few states in India. Punjab is one example where diabetes outnumbers pre-diabetes. That means we've reached the peak of the epidemic. But across almost the rest of the country, the number of people with pre-diabetes is more than that of the people with diabetes. So the diabetes endemicity index is less than 1 as of now. And we are still yet to see the worst of this epidemic, the epidemic of diabetes. We speak of the KG-A1C paradox in diabetes care. That's a separate matter. Maybe when Dr. Nitin Kapoor speaks on his topic, he'll allude to what the KG-A1C paradox is. But here we have a syndemic of diabetes and obesity. Next slide, please. And that is diabesity. Syndemic means that together at the same time, simultaneously, you have people who are overweight and obese, and you have people who have poor control of glucose. This is a syndemic. It's a devious duo because not only synergistic, much more than that, you end up actually worsening outcomes of every sort when you have both obesity and poorly controlled diabetes together. And this is unfortunately reality for almost all of our countrymen and women. When we look at the comorbidities, you can count them in multiple ways. Microvascular, like retinopathy and renal disease. Macrovascular, like heart disease. Albuminuria is an example of that. Mitogenic, such as cancer. Mood-related, like depression. Mechanical, like obstructive sleep apnea. And musculoskeletal, osteoarthritis, other aspects leading to impaired mobility. In fact, in overweight and type 2 diabetes together, we have something called the moan syndrome. When we were students, groans and moans would mean hyperpara. But now, mercifully, we're able to diagnose those people at an asymptomatic stage, hyperparathyroidism. Now, moans and groans means overweight and type 2 diabetes. The moan syndrome is musculoskeletal, muscular, that's M. O is osteo, that's bone. A is arthro, which is joint. And N is neuropathic. So you end up having multiple permutations, combinations of the Moan syndrome, whether it's because of muscle disease, osteoid disease, that's bone disease, muscle, joint disease, or nerve disease, neuropathy. In fact, now they have coined a new term, obesity-associated neuropathy. And Dr. Nitin Kapoor is an expert on that as well. Next slide, please. So we see this wide variety, this vast spectrum of comorbidities. And we see that the risk of mortality, not only morbidity, the risk of mortality also increases if you have this syndemic. If together you have diabetes and overweight, the risk of mortality goes up 7-fold. Now we have two choices. Either we can keep on speaking about all this, or we can do something. When we follow what we call a downstream approach, that means we try to tackle hyperglycemia. It becomes quite difficult for us. We see the results. The results are not all that good across the world. And it's like fighting a multi-headed hydra or a multi-headed cobra. You have to fight so many complications, so many comorbidities. It becomes very difficult to win the battle, to win the war. If, however, we were to go a little bit upstream, and if we were to fight overweight and obesity right at the very beginning of dysglycemia, that's like fighting a single enemy. And then the chances of success are more. So with this upstream approach, if we fight obesity or adiposopathy, perhaps we can do a much better job of preventing all these complications that our patients face. In India and in most parts of Asia, we are no stranger to the banyan tree. And the banyan tree, it's a tree which has lots of connotations for us. Historical, spiritual, cultural, religious. The banyan tree is known for its multiple roots. The banyan tree is also known for teamwork. It's known for sustainability, for longevity. And if we can follow this banyan tree ethos towards managing diabetes and obesity, perhaps we can do a better job for our fellow citizens. So in today's webinar, we'll speak about, first of all, our techniques and tools. How do we leverage the benefits of lifestyle modification along with pharmacotherapy? How do we integrate them together? Dr. Unikrishnan will speak to us about that. We then look at our targets. Is the target just glucose control, or is it weight management as well? Or perhaps both? We'll first talk about tools and techniques. Then we'll talk about targets. Dr. Vivian Lim from Singapore will share her experience with us. And then we'll talk about teamwork. how do we put everything together? How do we use various drugs to see if we can follow this upstream approach, or if we can use the banyan tree concept to manage diabetes and obesity together? Professor Nitin Kapoor will speak to us about this. Next slide, please. Like I said, we have two choices. We can either just speak about all this, or we can act. Let's talk about these changing paradigms over the next 1.5 hours or so that when we go back to our clinics tomorrow, we are best prepared to begin acting towards changing our perceptions and our actions. With this, a warm welcome to Dr. A.G. Unikrishnan, a very close friend. We've been together for 2.5 decades now. It's Dr. Unni, how fast time flies. It's difficult, to think of that. Dr. Unni is head of clinical care research and education at the world famous Chalaram Diabetes Institute in Pune, in Maharashtra. He has been past editor of the Indian Journal of Endocrinology Metabolism and the founder editor and editor-in-chief of the Journal of Thyroid Research and Practice. He brought that to global heights, starting from nowhere. As far as awards and acknowledgements are concerned, you name it and he has won it. I did my fellowship at almost the same time as he did, and he never left any prize for any of any of the rest of us to win. So, Dr. Unni, warm welcome to this webinar. What's your opinion about changing paradigms in obesity, and what would you like to speak to us about today?
Thank you, Sanjay. And I'd like to begin by saying that obesity and type 2 diabetes are closely linked. And I really appreciate Sanjay's idea of an upstream approach. Let me go ahead and share my slides. Can you see my slides?
I think it's about, yeah, now we can. Perfect.
So answering your question, Sanjay, I think shifts, uncertainty is the nature of life, and science progresses, and always change is constant. Guidelines change. As science comes, we update ourselves. What we thought was good yesterday may not be good today and may still be good tomorrow. So science keeps changing, and the other way around too. So my task is to talk about the integrated role of lifestyle modifications and, of course, the positioning of modern medicines for cardiometabolic health. With the permission of Dr. Sanjay and with the other organizers, let me start my talk, and also would like to acknowledge and thank the organizers for including this topic and for including me to speak here. These are my disclosures, and this is going to be my agenda. I'll talk about a brief background, going on to then lifestyle modifications, that'll be the key. Then the evidence from certain lifestyle intervention studies, and then go on to whether and where modern medicine can fit in. We know that cardiovascular risk in type 2 diabetes is paramount, and the answer is not just glucose control. The answer lies in a combination of lifestyle modification, anti-inflammatory therapy, weight management, platelet inhibition, management of dyslipidemia, insulin resistance, so on and so forth. And that brings us to the crucial question of lifestyle modifications. Lifestyle modifications can be divided into 4. Let's first look at nutrition therapy. Nutrition therapy aims to achieve targets, the glycemic, the weight, the lipid, and the blood pressure targets, addresses individual nutrition needs and delays diabetes and its complications, and provides tools for planning the meals in an appropriate manner. If you look at the American Diabetes Association nutrition therapies overall recommendations, it is clearly recommended, and this is level A evidence, that for patients with type 2 diabetes, obesity, or overweight, a minimum of 5% of weight loss is to be achieved and maintained, and that must be done in a very individualized manner. To summarize, individualization focuses on low carbohydrate dietary patterns with calorie restriction, and replacing saturated fats with unsaturated fats. And of course, a largely vegetarian or plant-based diet with some fish and also egg consumption, and with low-fat protein sources, dietary fiber, and salt restriction seems to be the way the nutrition evidence is headed. Let me now go on to physical activity. Physical activity is wonderful for improving blood glucose. It's excellent to reduce the A1C. It improves cardiovascular fitness. It improves insulin sensitivity, and it improves the muscle strength. And as I speak, I could hear the fireworks in the background, and they're still on. I don't know why. There's no festival, but maybe somebody is clapping for the importance of physical activity, which I'm stressing on. Well, it does all these things, but it's not a magic pill for weight loss. Many patients think that exercise will help in severe weight loss. That's not true. A lot of exercise has to be done to just lose weight, but that doesn't mean exercise isn't important. Exercise is important to control the glucose, to reduce cardiovascular risk. What is recommended is 150 minutes of vigorous, intense physical activity and 2 to 3 sessions on resistance exercises. And remember, this is very important, on non-consecutive days to allow the muscle to recover. 2 to 3 times per week of flexibility and balance training in older people. And of course, prolonged sitting interrupted by every 30 minutes is important. To manage the weight is important because you need to prevent pre-diabetes to diabetes, and from diabetes to diabetes-related complications. You need to improve the blood pressure, the lipids, improve insulin sensitivity, and behavior change, dietary change, physical activity, and aerobic activity are both important. And this study shows that with increasing variability, the fluctuation of weight, or the yo-yo phenomena, as you go from left to right, the increase in variability, as shown in the x-axis, is associated with an increase in both coronary event and rates of cardiovascular events in general, and the p is less than 0.001. And this has been shown in several studies, and therefore these are the recommendations for weight. Lose minimum 5 to 7% of body weight. Any diet which can help in aggressively lowering weight can be tried, but with a doctor's or a dietitian's help. And weight reduction improves glucose control, whether achieved with medications or with surgery. Smoking cessation is often ignored, and both passive smoking and active smoking has to be discouraged, because smoking cessation itself, at 1 year after stopping smoking, patients can improve their metabolic parameters as well as improve their blood pressure and albuminuria. And smoking cessation can reduce cardiovascular disease despite an increase in weight. And structured advice is important, and all patients should be advised not to smoke cigarettes or tobacco products or e-cigarettes. So for smoking cessation, one has to ask, advise about smoking, assess the degree of addiction and readiness to quit, assist with a cessation strategy, and schedule regular follow-ups on that. So after having looked at the background, and now after having looked at the lifestyle modifications, let us look at the evidence from intensive lifestyle modifications. Intensive lifestyle modification in this look-ahead trial did not make an impact on cardiovascular outcomes, but had an effect on weight and other comorbidities, like, for instance, blood pressure, triglycerides, HDL, and LDL. You can see the HDL going up and the LDL going down. And indeed, probably one of the few healthy ways of increasing HDL is physical activity, diet, and exercise. So 5% weight loss in the year following diabetes diagnosis was associated with a 48% lower risk of cardiovascular disease. So this is a Darching diabetes prevention study, which again showed that lifestyle intervention can reduce all-cause mortality. And you can see that the cumulative death incidence came down statistically significantly, the p-value just reaching significance at 0.049. But there are challenges with lifestyle modification. It's not easy. Achieving results, coping with challenges, social support, relatedness, the community, the patient, the society, the family, all have to come together to help the patient. And that's because of this. You can see both the look ahead study and the direct trial. And this is data from the look ahead study. You can see that with intensive lifestyle intervention, there was a good increase, good remission of diabetes. But diabetes, simply giving diabetes support and education, also there was some benefit. But you can see that with time, the remission rates came down. And in the direct trial, which was done by Dr. Roy Taylor from Newcastle in UK, at the end of 3 years, 50% patients achieved remission. Remission means type 2 diabetes, HbA1c reduced to below 5.7 with all medicine stopped and persisting like that. But only 23% were in remission at the end of 5 years. And that means relapses can occur and relapses have to be prevented. What is the role of modern medicine? Many times, many people feel that diet and exercise is important to reverse diabetes or cause remission of type 2 diabetes. The new name is remission of type 2 diabetes. We doctors are not against diet and exercise. We are for diet and exercise. But there is a time when diet and exercise isn't enough and pharmacotherapy is needed in addition to lifestyle modification, because lifestyle modifications are often followed by weight regain, whether it is very low calorie diet, modified diet, or very low calorie diet plus behavioral therapy. And if you see the years post intervention, you can see the weight going up back. And that is why you see pharmacotherapy plus lifestyle modifications can cause sustained weight loss benefits. And that is why several drugs, including semaglutide, liraglutide, and so many other drugs have been approved internationally. And that is also why our guidelines, international guidelines, say that in people who have heart failure, chronic kidney disease, cardiovascular disease, or multiple risk factors, drugs which control the glucose help in weight loss and have pleiotropic effects such as GLP-1 receptor agonists and SGLT2 are important agents. When you start a patient on diet and lifestyle, if your patient is on insulin, remember, if your patient wants to go for an aggressive lifestyle intervention, tell them to take 1/3 of the usual basal insulin dose for the controlled patient and skip the dose if the patient doesn't eat carbohydrates, and skip that day of sulfonylureas if the patient is taking a 24-hour fast. Physical activity. We've heard of many patients, many people having a cardiovascular attack during exercise. So people with diabetes over the age of 40 or with risk factors should have a CVD risk assessment. High-risk people start with low-intensity exercise and then increase in intensity and duration. People with retinopathy can have vitreous hemorrhage, so do not do exercises like weightlifting that can increase the intraretinal pressure. People with neuropathy, Charcot's foot, walking for long distance can precipitate a pressure ulcer, and that people should be asked to walk for short duration. So therefore, friends, I'd like to end my presentation by saying that lifestyle modification is of paramount importance in preventing and managing cardiovascular risk factors in type 2 diabetes. Individualized goals should be planned back with the background of patient's need, access, preferences, the choice of the patient, and the best evidence and experience of the treating doctor or healthcare provider. Lifestyle modification, initially the results are great, but sustaining it, keeping diabetes in remission, not very easy. And therefore, in many times, pharmacotherapy is needed. If there's beta cell failure, for example, and that is persistent, you require insulin or you require other drugs. An early initiation of combination pharmacotherapy with lifestyle modification that will give you a good weight loss, glucose control, which is sustainable. Once more, friends, it's been a delight to discuss this topic, which is very close to me, and with Dr. Sanjay, who's also very close to me. And thank you, Nova Nordisk.
Thank you, Dr. Oni Krishnan. Great start to today's discussion. And what Dr. Oni says is that lifestyle is important. Of course, we need to optimize our lifestyle, but the vast majority of us will need some kind of support. And that support can come through pharmacotherapy. We have with us Dr. Vivian Lim. Warm welcome, madam. Madam, it's been great being with you. Madam is a shining star of Asian endocrinology. She has been organizing secretary of the International Congress of Endocrinology, which was held in 2022 at Singapore. And what I know is that the women endocrinologists of India and Sri Lanka, South Asia, all look up to her. So you're an inspiration for not only for the ladies, for the men as well. We wish we could be like you. I'm also reminded, Dr. Vivian, suddenly about a Nepalese endocrinologist, what she said. Her name is Dr. Mimi Giri, and what she said is that, there are some things which people with Y chromosomes can do. There are some things which people with X chromosomes can do. But if you want to be special, like if you want to have the Health Manpower Development Scholarship from the Ministry of Health, if you want to be past president of the ASEAN Federation of Endocrine Societies, and if you want to be on the executive committee of the International Society of Endocrinology, in short, if you want to be Vivian Lim or like her, then you need 2 X chromosomes. Is that right, madam? What does that second X chromosome do? Does it make you special in the brain?
Makes us all very good. And health, as you can see from the health statistics, that the women live longer. Yeah. Well, thank you very much, Sanjay, for that kind welcome.
So we've talked about the importance of lifestyle, but what about targets, Dr. Vivian? When we are managing diabetes, diabesity, when we are managing obesity, adiposopathy, what targets should we focus on? And how should we do that? What should our approach be? Would you like to share your experience with us?
Well, thank you very much, Sanjay, once again for that. You can hear me well, right?
Perfectly.
Okay, excellent, very good. Now I'm going to just share my screen first. Where is my screen? There we go. Okay, so thank you very much for the organizers for asking me to give this talk. It's a really, really long title, but I like the 2 things in it, and they are my passions. A few of my passions. One of them is obesity or weight management, and the other one is type 2 diabetes management. Now, to seek in the talk, because we don't have much time, these are my financial disclosures. I received gratuity from Nova Nordisk for this talk. So the 2 pandemics of our time, they are actually one pandemic, and that is not going to be COVID. It's the diabetes, it's not epidemic, but pandemic now. And we do know then that every 6 seconds, 1 person dies from diabetes, not to mention worsened by obesity. Now, these obesity rates across the world, they're increasing. It doesn't matter whether they're boys, they're girls, whether they have XY or XX chromosomes, they're increasing and postulated to increase even more by 2035. And if the adults 20 years and above, you can see the same thing, whether they have XY chromosome, XX chromosome, it's increasing. Now, what about diabetes? It's the same. And you see that the postulated increase from 2015 to 2040 in the Southeast Asian region is ×2. But experts and all of you know that I feel that this is a gross underestimation of the diabetes levels. It's going to triple, it's probably going to quadruple at the same time. And most of them, 3/4 of them with diabetes, actually reside in lower income to middle income countries. So the double whammy situation. Now, what we'll be talking about in the talk then is the magnitude of this problem. We saw the global one, and we wanted to know its negative impact on each other, that double whammy situation. The second one is treatment strategy, a logical approach to this pandemic, and challenges of weight management in diabetic patients. So let's talk about the first one. Now, what about the magnitude of this problem? I gave you the global rates, but the global rates are actually an underestimation because each Asian country or each country should have their own BMI cutoff points, as alluded before by Sanjay. Now, what is BMI? It's weight in kilograms divided by square of the height in meters. That is one way of measuring the adiposity in the person. Now, if you use the Caucasian standards, you know that 30 and above is obesity. But unfortunately, for the Asians and the Southeast Asians, Singapore is Southeast Asia, they at the level of 30 is a bit too high for us because we have consequences of that obesity from a lower BMI. So for South Asia, we're taking about 25 as obesity, Southeast Asia 27.5. Now, another method of noticing that obesity or getting that, it's waist circumference, which is women more than 80 and men more than 90. So what about the magnitude of the problem in India? So looking at this here, this is using WHO criteria, which is 24.6% is overweight. But if you use South Asian criteria, it becomes 15. But then look at that obesity levels. It's more than triple if you use South Asian levels of 25 and above. This is so in total, half of the population of India will be overweight and obese. Now, if you put that into consideration, the prevalence of abdominal obesity, in which you can have a normal BMI, but abdominal obesity is 39.5%, which means that the majority of the country is either overweight or obese. Obesity, I don't have to belabor the point, comes with many problems, metabolic, physical, and of course, if you're cutting around 20, 30, 40, 50, I just saw someone which is 70 kilograms excess weight, you're going to have a problem if you carry out 24/7, 365 days. So this is obesity associated increase, and it also comes with with cardiovascular event with increasing BMI. So if you look at this is males. From males going up the BMI group, you see a much higher increase. It's an increase in cardiovascular events, and it's the similar figures for that. This is females. For that of females. What does that mean then in terms of percentages? With this, it's the likelihood of incident diabetes is more than 2 times if people with overweight and obesity. Now, with every 1 unit increase in BMI, the probability of being diabetic increases in 1%, 1.5% amongst overweight and obese individuals. And even among those who are non-overweight, it still increases by 0.5%. And the greater the weight, there is a greater risk of getting diabetes, such that you actually 22 times increased risk of developing diabetes with severe obesity. And this double whammy situation comes in again here. So obesity drives diabetes. But at the same time, once you get diabetes, that higher BMI comes with it as well, an increased risk of complications. So an increase of 1% in increase in BMI in that diabetic patient increases 5% microvascular complications. Now, so we talked about the magnitude of problems, which is underestimated. If you use a WHO BMI criteria, we have a negative impact of obesity on diabetes and vice versa, worsening the situations. And obesity itself comes with its own host of other complications as well as with diabetes. Now, treatment, let's talk about then treatment strategy and the logical approach. Now, let's look at this patient. Very common now. They're getting younger and younger. Mr. ABC here, 40 years old, South Asian male, annual health screening. They come in, he's totally asymptomatic. Annual health screening found that his fasting glucose was 8.1 millimoles per liter. That's times 18 to get milligrams per deciliter. HbA1c is 7.5%. BMI is 27. Abdominal girth is 100 centimeters. He didn't think he was that big. He thought that he was normal actually. Blood pressure was 150/90, high uric acid, high triglycerides, low HDL, snores at night, knee pain, and some back pain. Now, all of you ones in the audience who I'm preaching to the choir, of course, will know that these are all complications that come with obesity. That's why when you find one, you find everything. So then the question that is, what do we want to do? Just reflect. You think about it. I'm going to talk on. You think about it. What do you want to do in this patient? What's your approach? Now, if we looked at diabetes medications through the years, we start with 1921. Let's hear it from you. 1921. What is this? Insulin. Now, through the years, not updated, sorry, but through the years, you see the ever-changing faces of medications. And not just that, but the way of monitoring glucose, insulin technology has always improved. Now, I wanted to highlight the latest three, which is one is bariatric surgery, rather the three that comes with weight loss. GLP-1s, SGLT2, with the GLP-1s coming very effectively in weight loss. Now, this now then shows the changing outcomes and the changing outcomes that we want to chase after for diabetic patients. Previously, when we did not have that much medications, just to treat diabetes, just to prevent that death, we had insulin, we had metformin and sulfonylureas. So the aim then is improve A1C. Then later, it became improving A1C without hypoglycemia, without weight gain. And then next, it became cardiovascular renal impacts when we realized how good they were. And now we know that some of the drugs, especially the GLP-1s, as salubrious, are very, very good, effective weight loss drugs. And therefore, weight now becomes a target, as it should be logically, because it drives lots of evils. And so at the same time, when you are treating that weight, you're not just treating diabetes, you're treating lots of other things, because it is the root cause of many other evils, not just metabolic, but as well as cardiovascular, but also physical. Now, let's look then at weight loss. This weight loss, it actually reduces the risk of developing type 2 diabetes. Why are we just talking about diabetes and treatment of obesity then? We should prevent it by all costs, because prevention is always better and cheaper than cure. And in this study, we see that with increasing loss, the incidence of diabetes actually decreases. So a weight reduction of every 1 kilogram reduces risk of diabetes development by 16%. Now, what about in diabetes itself, the patient who already has diabetes? The weight loss alone then can lead to a reduction in A1C. And it also obviously leads to a reduction in fasting blood sugars. And this is the holy grail that everybody's trying to find, the ultimate aim in which this diabetes remission. And we find that a greater weight loss led to greater proportion of patients achieving and maintaining remission, and 1.25 times odds of diabetes remission at 2 years for every kilogram of weight loss. Now, this is an American Diabetes Association 2023 guidelines. I don't want you to read the whole thing, just wanted to go through the broad categories here. So basically every year the ADA come up with this guideline in January, and this is our latest incarnation. I've always liked it because it's multicolored, but unfortunately very, very complex. So here's talking about pharmacologic approach to glycemic treatment. So in this case, because if you remember the advancing technology of diabetes management in terms of the more and more the bad drugs that's out there in the market now, we can target things beyond A1C. And we have on the left here, you know about cardiovascular and renal approach or precedence, and you can see, and here you can already see that GLP-1s which are there. But I wanted to bring you to this area here, and I'm going to, expand it up for you and see. It finally gave its own weight as weight management. So it's not just HbA1c glycemic goals, but also weight management goals. Therefore, recognizing the importance of obesity with regards to diabetes and vice versa. So if we are choosing glycemic management approaches, one of the very high ones, if you look under high and very high, GLP-1s predominate there. But if you look over here, which is my favorite over here, is achievement and maintenance of weight management goals and the efficacy for weight loss. Again, you look at here, it is dominated by the GLP-1s, and it's really because of the GLP-1s advent in 2008, somewhere in the late 2000s, that we are allow us then to put this in as one of our goals, objectively and realistically, to be able to achieve it. Now let's go back then to Mr. ABC here, and with this 40-year-old South Asian male whose annual screening opened up an entire can of worms, in which you know that he's obese as class 1, and now he has also recently been diagnosed with diabetes, with dyslipidemia, high uric acid, and hypertension, not to mention, obstructive sleep apnea. So what would you want to do then? I mean, the logical thing about this whole thing would be that you tackle the root cause of all evils, which is obesity. If you can have one drug then to do everything, wouldn't that be better than to treat all the downstream effects, like treat diabetes, treat high blood pressure, treat this cholesterol, treat everything, treat that root cause, which is obesity, and if possible, we lose as much as we can realistically, and we see what happens to the rest of the consequences. Now, of course, for this must be comprehensive, it must be individualized, dependent on the circumstances, the drugs which are available in the particular country where the patient resides, and that's why the individualization comes in. And just another thing as well is the HbA1c. He's 40 years old. All international guidelines is at less than 7% or less than even 6.5%. And it must be individualized. He's so young. Now in Singapore, someone can live, and 10% of our countrymen or women are South Asians. And we can live until 80 plus. So he has he's only lived for half his life. I want to give him as long as possible and a good quality of life. So for this case, for him then, I would like to have a HbA1c which is less than 6.5% or as near normal as possible. So I would start for him a GLP-1. We will discuss why, and we will discuss what about the other, treating the other comorbidities at the same time. Now then, at this point, we are going to then discuss we talked about treatment strategy and logical approaches, which is now getting that weight loss in to the diabetic patients and getting it first, rather than as a side point, because, with that, I might be able to get diabetes remission. I also will treat all the rest of the other consequences that comes from it. Now, then let's go on into the challenges of weight management in diabetic patients. Now, this is one of my passions, which is I like to talk about myths and misconceptions in the obesity management itself. Now, diabetic patients who are obese is no different in a way from any other obese patients who have lots of misconceptions, and even amongst medical profession, that myth and misconception prevails. So I just wanted to show you this person. It's not a patient. It's this. Now she lost 35 kilograms. So this is before and after. There is no logical reason why she should put it back on at all. It doesn't make sense, right? I mean, she looks so good. Why would she want to put it back on? But the problem is that she did put it back on. This was Asia's Top Loser season 2, and she lost 35 kilograms, and she documented what happened. She rebounded. It got even worse. So the myth and misconception that lots of my patients, all my patients actually have, I haven't seen one who tells me up front that it's not a lack of discipline. It's a disease. I've never seen a single one. I'll be happy for the panelists to tell me that they actually saw a single patient who said that. So they all think that it's because they're lazy, they're not exercised, they have a lack of discipline, they have a lack of morals, whatever. But obesity is a chronic, relapsing, remitting disease. It's like thyroid, isn't it? So obesity is a disease. Now, what does that mean? Look at this entire homeostatic system, which also encompasses lots and lots of different hormones from the brain, from everywhere else, pancreas, everything, to keep that steady state. And it interacts with the environment, your behavior, your hedonistic lifestyle tendencies, everything, to create that steady state. What does steady state mean? Imagine 50 calories excess a day. That's a small apple, or half an apple, big apple. 50 calories excess. You don't even think about it. One small piece of chocolate, 3 potato chips. That would come to an increase of 2.6 kilograms per year. And yet many people remain stable, at least for maybe 1 or 2 years, or 2 or 3 years. That stability is the homeostatic system, which keeps, without you thinking, it will keep that weight. This is an incredible system that keeps weight stable, whether you are underweight, whether you are lean, or whether you are obese. Think of that 80-year-old, 40-kilogram woman. You try to get her to put on weight, you can't. She puts on 5 kilograms. The minute she doesn't think about it, boom, she goes back to 40 kilograms. Similarly, for an obese person, this is a hardwiring. This is a set point that you have to fight against. How can you keep fighting it day in and day out? So what happens then if you go and do this? So you've got lots and lots of all the diets that come on, any diet under the sun. So long as your input is less than your output, you will lose weight. But what happens then? Remember that homeostatic mechanism, which is so strong. You lose 5 kilograms. It doesn't like it. Everything it wants to fire, so it increases your craving, decreases your satiety, makes you eat more, makes you maybe exercise less, do less physical activity, eat more rich food, whatever. Anything in you, everything in you wants to go back up to the set point, and a lot of people rebound. And we already heard about what happens if you have a yo-yo variability in weight as well. So these people just keep going on, and they are exhausted at heartsick by the time they come to see me. Now, so weight loss is actually the easiest part, and it is weight maintenance that is the killer, and it's because of that homeostatic set point that keeps wanting it to go up. So we've seen this look ahead study, but I wanted to bring your attention to this. This is after 8 years of intensive lifestyle, which includes monthly counseling, dietitians, whatnot, chatting with each other. 4.7%. That's what you get. You need at least 5% to have sort of good effect. But 4.7%. 4.7% is better than nothing, but in a severely obese individual, he will still remain obese. Let's look at just very quickly. This is liraglutide. This is semaglutide, 15%. This is tirzepatide, 24%. We are muscling into territory, which is that of bariatric surgery, which is 20% to 30%. Let's compare it with this, which is lifestyle, which is 5%. And remember that this is a chronic, remitting, relapsing disease. And this is semaglutide. And to show that it's the same with lifestyle, if you stop the medication, if you stop that intensive thing, what's going to happen? It's just going to go up. And the interesting thing is it goes up to about 5%. This is about 4.57%. It's about the same. Now, the problem I have with a lot of my patients is that they don't want to start on certain weight loss drugs or drugs that would be good for them in terms of weight loss. They feel that it's a discipline problem, and you need to tell them otherwise. You need to convince them that this is a good drug to have for a diabetic patient. So that's one of the problems. And the other problem that I'm seeing is that patients with diabetes actually lose less weight than those without diabetes. And we see that definitely weight loss comes with beneficial effects. So now this is the change in baseline for those without diabetes in the gray bar. Now, compared to those with diabetes, the same trial, we find that it's much less, or rather it's lesser, which is another problem that we have. Again, a double whammy situation where with weight in diabetes population, worsening the entire spectrum. So now going back to that person and going back to the person. So what I would do is definitely sit them down, as I've mentioned, sit them down. We discuss about obesity, we discuss about diabetes, we discuss about what is the best way forward. And I would definitely start a GLP-1 for this person. With one medicine, I kill two birds with one stone, both the diabetes as well as the obesity. And then it will come with other good effects. I definitely would want to sit him down and also discuss about the myths and misconceptions of obesity and obesity management. And that we were just, scraping the tip of the iceberg about discussing about it being a chronic, remitting, relapsing disease. There are other things like misperception about caloric expenditure, caloric estimation of caloric intake at the same time. Lots of things to try to shift have that paradigm shift in their mind towards thinking that this is a chronic disease. that is not just not working hard and not to blame themselves about it, to seek help about it and to start that medication and to also continue with that medication because it is a limiting and relapsing disease. So in conclusion, we talked about obesity and diabetes negatively impacting on each other and obesity driving the diabetes rates up. And with the advent of new medicines with proven weight loss benefit, this has then gained recognition finally as a goal of diabetes management on par with that of glycemic control with cardiorenal outcomes. And in diabetic patients, then weight loss itself has deleterious effects on multiple levels, not just on the diabetes itself, but also on the rest. And we talked about very briefly about challenges of weight management in diabetic patients and the myths and misconceptions that may plague this and may therefore handicap the management of obesity in these groups of people. And so this will lead me, therefore, to the paradigm shift to now really think about targeting the root cause of many evils, which is obesity, when you are looking at that newly diagnosed diabetes patients, and to put that at the forefront of your mind when you're deciding which medication you want to start with. I thank you very much, and I'll take any questions later. Thank you.
Thank you, Dr. Vivian. A great presentation. And when you began, you spoke about your passion. That comes through when you speak. So we can feel the passion coming through, the passion that you have to improve health in each and every person around you. Thank you, Dr. Vivian. We'll go on to our next talk before we take questions from the audience. And it's a pleasure to introduce Professor Nitin Kapoor, who is a consultant endocrinologist, professor and head of unit at the Department of Endocrinology at Christian Medical College in Vellore, Tamil Nadu. He also works at the prestigious Baker Institute in Melbourne, Australia. And he has coined the term barocrinology, which means the interaction between obesity and endocrinology. But Dr. Nitin, today our topic is barodiabetes, perhaps. And like Dr. Vivian said, it would be nice if we had one drug which could handle both things, which could obviate not only the concept, but even the discussion of KG-A1C paradox. So what would you like to speak about today? And before you begin that, perhaps what is the KG-A1C paradox and how has it hurt us over the past couple of decades while we've been managing diabetes?
Thank you, sir, for that very kind introduction. Thank you, Team Novo, for having me here. And, sir, answering your question about KG-A1C paradox, and I think our very understanding of this term has changed over the years. And I put a few slides on that, but maybe I should answer it right away, saying that the initial thought was that when we start managing patients with diabetes, we definitely improve their A1C, but unfortunately, their weight tends to go up. And that was the case because we had drugs at that time, which were mainly insulinotropic drugs or drugs which produce more insulin, or we used insulin, and both of which we know from our knowledge in physiology that insulin is anabolic. So it increases weight. But over the years, our terminology of KG-A1C paradox has changed, and I'll show you that in a couple of slides from now. But really, thank you so much, sir, and thank you, Team Novo, for having me here with two splendid talks by stalwarts before. I take this opportunity to present to you how we can have a single drug to target both obesity and diabetes, and that too if the drug is oral. So I'll take you through this four very brief headings that we have, looking at how GLP-1 RAs can help to target these multiple aspects in diabetes, of which diabetes and even more. We talk about what is the concept of having a peptide as a pill and how the science of that works. We look at the evidence as to how much weight an A1C can be reduced with the help of these drugs. And before I close, I'd also mention as to how and what are the factors or the disorders that can be targeted by this drug beyond diabetes and obesity. So we're just starting with the first aspect, and I think it is already very well covered that we know that diabetes has reached pandemic proportions globally, and we in the Southeast Asian region tend to lead the world with the world's largest number of people with diabetes, not only because of the population, but even our prevalence. in terms of numbers is high because we are ethnically prone to develop more diabetes. When you talk of obesity, and this is data from the National Family Health Survey, we know that about 30 to 40% of the Indian population is either overweight or obese. And very recent paper by Dr. Mohan's group talks about the ICMR INDIAP study looking at the prevalence of all the metabolic problems across India, both rural and urban. And just one glance at this statistics is giving a kind of a heart attack to all of us. And I know Professor Vivin Lim also showed this paper. So yes, there is a huge prevalence of diabetes that we are seeing currently in our country and in the region of Southeast Asia. About 25% of the population in India at this point is either diabetic or pre-diabetic. When you look at maximum prevalence in certain states, the numbers are even more scary. But for a change, just let's step back for a minute. And when we're talking of diabetes and obesity together, and if we were to plot our countries, the South Asian countries, on a map or on a graph, looking at diabetes prevalence, and as I mentioned, yes, we do score as one of the top countries throughout the world with one of the largest prevalence of diabetes at par with the United States and United Kingdom, as you can see here. But when we compare it to obesity, I think what we see is that we South Asian countries put together tend to have this kind of a paradox where our diabetes rates are very high and the obesity is increasing. The overall obesity is not as much as what we see in the West. And if I was to say this is another KGA1C paradox that we know. So normally by conventional teaching, what we are told is that as BMI increases, the HbA1c should go up. And when we look at the graph, if you have family history of diabetes, the graph is much more steeper. And unlike what KGA1C paradox was being told about, say about 10 years ago, in this paper, Dr. Kalra mentions how when the diabetes is controlled, the weight goes up. But I think the bigger paradox that we see today is not having this direct relationship between weight and BMI, and people with low or normal BMI can also have a high prevalence of diabetes. A couple of years ago, we looked at our community-based data from Vellore and trying to look at the prevalence of lean diabetes. Now, these are individuals who look lean, but they tend to have much higher body fat. And that's what we say in terms of our BMI adiposity seems to be very much different. A couple of years ago, we looked at the prevalence of this phenotype, so-called normal weight obesity. It's fairly high. About 1/3 of the population in this particular study had high body fat despite having normal BMI. So friends, cutting a long story short, what we are talking today about is diabetes management. I completely agree. Yes, we are also looking at obesity as a problem, but from a South Asian perspective, I think in people with diabetes who don't have obesity by so-called BMI standards, I think there's still a large proportion of them who have obesity in terms of fat. And therefore, drugs like these, which target both obesity and diabetes, would be something that would be definitely the need of the hour. But overall, our treatment strategies have definitely moved away from just glycemic control, just not only cardiac and renal protection, but also talking about weight. And there are other benefits as well. So when we look at the kind of drugs that are really available in the market in terms of managing diabetes and weight together, well, there are several of them. GLP-1 RAs definitely take one of the top positions. And we see that there are drugs which are either monoformulations or co-formulations which are available. And definitely semaglutide has stood up as one of the first drugs which has entered the market. And there are several trials not only gone beyond before this drug was in the market, but today there are also post-marketing trials happening. The Pioneer Real trial that's also happening here in Vellore is telling us very good data, very effective data in the South Asian population in terms of both glycemic control and weight loss. And that's what we would see in this particular presentation. So moving on to the second aspect of my talk, which is talking about how oral semaglutide is able to deliver a peptide in the form of a pill. And we know that usually peptides are not really given as a pill because they get degraded in the stomach. But here we have a GLP-1 analog, but we also have something called a snack, which is an absorption enhancer. And when both of these are combined together in the form of a pill, well, this helps in the absorption of the peptide in the gastric mucosa. When semaglutide and snack are combined and the drug enters into the gut and in the gastric mucosa, it does get absorbed and deliver the GLP-1 RA absolutely intact to the tissues and helps to produce its action. So let's look at the data, what is available in terms of the dual efficacy of A1C and weight reduction. There are umpteen number of trials that have been done. All of them are called pioneer trials. We at CMC Vellore have been part of a few of them, including the most recently published Pioneer Plus trial. And so there's 10 of these initial trials. The SOUL trial is still ongoing. Again, we're doing it here in Vellore, and many other studies on semaglutide, both injectable and oral, have been done. But if you're just trying to summarize and look at the quantum of glycemic control and weight loss that have been achieved with the help of these drugs, yes, the HbA1c reduction has been fantastic. We see that most of these patients in different trials have been recruited with a baseline HbA1c, a mean HbA1c of 8%. And with that, we get a reduction of 1.5%. But many times that's not the story. When we have any patients with diabetes, they may have much higher A1C. So if the baseline HbA1c is more than 9%, the quantum of reduction of A1C is even more, 2.6%. And I would say this indeed is one of the most potent oral antidiabetic drugs that we have in the Indian market at this point in time, or the South Asian region. Well, talking about weight loss, and we know that this drug is not only helping to reduce diabetes by the GLP-1 action on the pancreas, but this drug is also working on the hypothalamus, trying to reduce the hunger, increase the satiety, and therefore also helping in weight loss. And the quantum of weight loss that we see that has been seen in different studies across different pioneer programs is up to the scale of 5 kilograms. And mind you, this is an oral tablet. I don't see any other oral tablet that has reduced this quantum of weight loss so far, either in trials or in clinical practice. So yes, overall, patients with oral semaglutide have shown to achieve good quality of life, metabolic improvement, both in terms of diabetes and weight reduction. And obviously, the cardiovascular risk is also not increased. So definitely, with respect to obesity, about 1 in 2, that's 50% of people would achieve at least 5% weight loss, which used to be the standard dictum for weight loss in patients with diabetes to begin with. And about 20% of them, that is 1 in 5, would achieve a weight loss of about 10%. The other very interesting data which has come up from the pioneer trials is also they have looked into the body composition of people who've received this drug. And the initial worry among several physicians were that when this drug is reducing weight, is it reducing the muscle mass? Is it preferentially reducing muscle causing sarcopenia, or is it reducing fat, or is it reducing both? And I'm glad that many studies, including more recent studies, even on injectable semaglutide, where body composition has been checked, overall the impact is much more on the fat than the muscle, and overall this drug is not causing sarcopenia. And if we couple a good dietary change in a patient who's been started with these drugs with good protein supplementation, I think overall, yes, fat percentage is something that will be affected more. So with this, I move on to the multifactorial benefits beyond glycemia in patients with oral semaglutide. And yes, the first big thing that comes out is that, yes, there's about 20% reduction of the total daily of usage of insulin, which in turn is good because that also helps to reduce weight. So if your insulin reduction happens, that is good for weight reduction as well. In addition, when we talk of different inflammatory markers, be it HSARP, lipids, blood pressure, different components of metabolic syndrome, including the waist circumference, which again is something very important from a South Asian perspective, we see there is rapid improvement there. Better outcomes have been noted if there is an early initiation with the help of oral semaglutide in terms of A1C weight, but also in terms of overall type 2 diabetes related complications. When we talk of safety, again, we've got enough and more data from clinical trials, and even we are getting post-marketing trials data. So yes, we are confident in using this drug because we have so much human data which is available. Overall, the GI side effects are mild to moderate. Again, we are counseling our patients well how to take this drug and how to space it out, and what to expect the side effect to be and how it weans off with time. I think the patient acceptance can be fantastic. Overall, yes, a lower rate of severe hypoglycemia, and as compared to other GLP-1 RAs, it is well tolerated. So we've also known, and though we are at this point talking of 3, 7, and 14 milligrams of semaglutide, in the Pioneer Plus trial that we did here in Vellore, we get 25 and 50 milligrams. And most patients tolerated that well. That was for obesity. But the point that I'm driving here is that when patients can take 50 milligrams of the same tablet, I don't think we should be worried about 3, 7, and 14 mg for talking in terms of side effects. And this was a trial without placebo, so I was sure that all my patients are either getting 25 or 50 milligrams. So definitely 3, 7, 14 mg, you can prescribe without much fear of side effects. Overall, yes, you can use it in elderly patients, even safe in hepatic and renal impairment. Very few oral tablets are actually safe in liver disease. So that's an added point here. It's very important to give the right instructions to the patient. This patient should take the tablet early in the morning, empty stomach. And unlike many other drugs, which we tell the patient to take with a full glass of water, this is a drug that we would prescribe only with 120 ml, sip or two of water. And after taking this drug for 30 minutes, we are not going to advise them to eat or drink anything or take any other medication. So 30-minute gap is something that is helpful. We start with a lower dose of 3 milligrams, and after a month, we can go up to 7 milligrams, and then 14 milligrams is the continuation dose, which can be made regularly after that. And if they miss a dose, they should take the skip dose and take the next dose on the scheduled day. Well, this has also been endorsed by both our guidelines by the RSSDI and the Endocrine Society of India for use of patients with diabetes and obesity. So friends, with this, I would stop here. And basically what we're talking today about is a class of drug that can target both diabetes and obesity. This is the first time that we have a peptide as a pill that can handle A1C reduction to the scale of 1.5%. If your patient had very high glucose values, then up to 2.5%. Along with that, a 5% weight loss, and at least a 50% of your patients having achieve 5% of weight loss. So that is significant. Overall, from a South Asian perspective, despite people not having high BMIs, we know we have more abdominal obesity, and again, evidence to show that there is reduction in fat, there is reduction in waist circumference as well. So I think with this, I would stop here, but would be happy to take questions.
Thank you, Professor Kapoor. Excellent presentation. And thank you to everyone who has continued being with us today. We've had wonderful discussions on virtually everything under the sun of obesity and diabetes. So many things to discuss. Dr. Unni, there's a question from the audience. You say that lifestyle and pharmacotherapy should go together. Usually they are synergistic. But can you think of any instances where two rights or two correct actions end up creating an error? One lifestyle therapy or diet and one pharmacotherapy, if you put them together, you end up in a life-threatening complication.
Well, I can think of a few. One is, of course, if you give, say, sulfonylureas for diabetes, and you end up controlling the blood sugar level, but putting the patient at risk of hypoglycemia or weight gain. Now, the second, of course, that comes to mind is SGLT2 inhibitors, which control the blood glucose levels well, but come at the risk of urogenital infections and also euglycemic or even hyperglycemic ketoacidosis, as is not uncommon. So these are some examples where, with good intention, you use a medicine to target a particular biomarker of diabetes, but end up with a complication. I think the answer lies in judiciously selecting the right patient for the right therapy.
And perhaps being aware of changes, like supposing I have a patient on SGLT2 inhibitor and the person suddenly decides to go on a keto diet without telling me or without me asking her. I mean, then you can get in trouble. So there should be crosstalk.
Yes, absolutely.
Dr. Vivian, how common is it to see maybe traditional Chinese medicine or any other traditional Asian medicine interfering with our effects? For example, Dr. Nitin has spoken about semaglutide. Now, that should be taken on an empty stomach. And in India, at least in North India, we have these multiple fats. So suddenly the patient will start taking fenugreek water or fenugreek seeds early in the morning after waking up. And they won't even tell you because it's part of culture, it's part of society. It's not that they're hiding something. It can be coriander water, it can be fenugreek water, it can be a million other spices. They just think it's part of life. They don't even feel the need to tell us. And then you end up reducing the absorption of thyroxine or semaglutide and then doing a million other tests. How common is that in your practice?
I think it's definitely common enough, but probably not to the degree that you are going to see in India from what I'm understanding from what you're telling me. But what they are taking more of is because we're a very cosmopolitan, westernized country, so they will take 1,000,001 supplements, thinking that supplements are natural. So they will say, I don't want semaglutide, but I want, and they will take 10 bottles of supplement. God knows where it's from. And then you have to go and address with the misconceptions. But if they're taking it, I think in general, they would be understanding that if they're taking it, we tell them the instructions with water. So they would think that, okay, water is water, and they probably won't put it in fenugreek or something else. So for that part, not really. Just interactions otherwhere else possible.
Yeah, thanks. Professor Nitin, you spoke about various doses of semaglutide. 3, 7, and 14 milligram are available in the Indian market. And 25 and 50 milligram oral formulations, you said you've just studied them. The question from the audience is, if my patient's HbA1c comes down to 5.2%, and it's a sustained 5.2% today and 3 months later, should I reduce, and my patient is on 7 milligram of semaglutide, should I reduce to 3 milligram or should I continue 7?
Right. So I think that's a very practical question. So overall in our Indian practice, first thing is I need to make sure that HbA1c is completely reliable in terms of hemoglobin, whether it is correlating with our patients' symptomatic hypoglycemias if they are having, especially if they are checking their glucose values periodically. So if these two things are ruled out, and I really trust that the HbA1c is 5.2%, after having started semaglutide, I would say this patient is getting better, probably in terms of weight loss, which has improved the glycemic control so much. So will I reduce the tablet or will I continue the tablet? I think would again be in discussion with the patient, but yes, I can continue the tablet because this tablet has been used even in patients with obesity without diabetes, though not yet approved in India for that indication. Just like to highlight that to manage obesity like a chronic disease, it's not like weight comes down, I reduce the tablet and then it will go up. So I would probably continue, provided there's no symptomatic hypoglycemia, which is unlikely, and if the patient is able to afford the tablet.
Dr. Unni, the vascular benefits of semaglutide, that would be another thing to speak to the patient about. Like you're taking 7 milligram, you're doing fine. HbA1c is just one out of many markers. And this molecule will help you improve multiple markers apart from the HbA1c as well. How can we use such kind of talk to how can we use pharmacotherapy like semaglutide to enhance acceptance and adherence to lifestyle modification? Will the pharmacotherapy help us do a better job of lifestyle modification?
Well, I think yes, because if you look at semaglutide, and if you look at semaglutide in particular and GLP-1s in general, there are studies which show that taking GLP-1 can decrease the intake of carbohydrate-rich food and can also suppress appetite that we all know. But particularly, there is a reduction in calorie intake as well. So there is a reduction in calorie, there's a reduction in carb, and there is a reduction in appetite, and there is satiety. So all these, probably through the POMC melanocortin 4 receptor pathway, and also through the vagus, there are central actions of semaglutide which make it probably easier for the patient to follow diet and exercise, particularly calorie reduction is a benefit of GLP-1. And also, wherever an anti-diabetes drug has resulted in a reduction in calories, it could be GLP-1, it could be SGLT2 inhibitor, it could even be acarbose, which decreases the glucose absorption. So some sort of mimicking therapies that mimic a low-carb diet, those therapies have been shown to reduce cardiovascular outcomes. And that's true with GLP-1, SGLT2, and even acarbose in the STOP and IDDM trial.
That makes sense. What you're saying is right. And now there's a question, Dr. Vivian, from the audience. You spoke of adiposity or obesity and diabetes together. The question is, it's a very specific question. How early should we start targeting adiposity or obesity in persons with diabetes?
Right from the very beginning. In fact, before you get diabetes, I'm targeting them. So if my patient comes, so generally I've got patients walking into my clinic. They are 14 years old, they are 18 years old, and they come with obesity because they're dragged by their parents. You have to look for it. If you have to do an oral glucose tolerance test, do the oral glucose tolerance test. I will not be shocked at all when they come in with frank diabetes, even at 14 years of age, because we are dealing with really, really frank obesity. They could be class 3 obesity and yet 14 years of age. So then I would be targeting, even if they didn't have it, I would target obesity first to prevent all the cardiovascular and all the metabolic and physical effects of obesity. It's only at the later stage. It's actually downstream effect. If I get them when you're diabetic, I've already failed, because I should have prevented that diabetes from even happening by tackling the obesity. Only when I could not do that, then I would target obesity with diabetes. So that would be the first drug I use. I would love it if I could use that, but I am mindful of the fact that you need to be individualized to the country, and the circumstances of the patient. So that's a practical approach to do. Finances, of course, comes into play. And do you have that drug that you want where you are practicing?
And Dr. Nitin, Madam just spoke about 14-year-old children with obesity. How common is that in your practice? 14, less than 14?
Yes, so I think it is becoming more and more common with every passing day. And I think we are seeing significant number of children with obesity. And Vellore is not really a big metropolitan city. About 6 years ago, we went to schools in Vellore, 4 different schools, to study the prevalence of obesity. And we were surprised that 30% of school children between the classes of 9 to 12 had obesity, not overweight, obesity. So that's huge. 1/3 of a population in a second-tier city in India has that. I mean, it's going to be much more in other big cities.
Any differences that you see in your OPD, boys versus girls, family history of obesity? Would you say that obesity is a communicable disease today?
Right. So, yes, I think the best statement that would describe that is obesity runs in the family because nobody runs in the family. And, people would like to, imitate. Children would imitate their parents. So if parents are not restricting their diet or have habits of, not really doing good physical activity, then the children would definitely emulate them, and therefore the whole family could put on weight. So that way is one way it would be a communicable disease, because though it's not getting transmitted with a bug or an infection, but at least mentally it is getting transmitted.
Dr. Uni, there are animal models of obesity, viral models, many of them. And there are a couple where viruses have been shown to induce obesity in human beings as well. Now, you are a very large hospital and you went through the COVID-19 pandemic. Maharashtra is a state which led from the front in India's fight against COVID. Has COVID-19 contributed to obesity, to diabetes, to diabetes, sarcopenic obesity?
Well, I think COVID-19 has contributed, but not in all patients. I think when COVID-19 struck, there were some categories of patients. For example, one group who were, for example, Pune being an IT city, as people working in the software sector could suddenly work from home. And when they started working from home, they found they had more time on their hands. So they exercise, they control their diet. They've been wanting to do it for a long time, and they had excellent control. The other group is sadly the group where people were not able to take a proper nutritious diet. Older people who were worried about going out to exercise, and some people had intense stress, worry, and that kind of people did not monitor their glucose and ended up having higher blood sugar levels. And then, of course, there is this worry about new onset type 1 diabetes, which I'm really skeptical, but there is some data to say that new onset type 1 diabetes occurring after COVID. We've seen a few cases, but I'm not really convinced that it is 100% related to COVID. But yes, COVID seems to have had an impact. So yes, I think maybe these are the 2-3 groups of patients we saw. Majority of people, I think, had a worsening of their diabetes control because of stress and lack of avenues to exercise.
Dr. Vivian, there are 2 questions for you from the audience. The first is, why is it so difficult to lose weight? That's the question.
I like that question. Thank you for asking that question. I didn't know how to put it into my talk and not bust my time. Think about it this way. Our genes really don't change that much. 5 million years ago, which is nothing in this earth, 5 million years ago, the gene which was the fittest, and remember, survival of the fittest is the gene that can give you 3 weeks of starvation and still survive. So everyone who had that gene will survive because 3 weeks of starvation. So the rest were all killed off. Now you fast forward now to our day and age with processed food, highly processed food, so much food everywhere else, even in rural, even in refugee camps now, right? And so that same gene, which gave you such a wonderful survival advantage, and the majority will have it because survival of the fittest, right? Now that same gene now interacts with the environment, with you, with everything. And the stronger that gene was, the bigger your size is. I mean, simplistically put it. So now this is your genetic set point. Your set point, some people's set point just goes up, 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 up. Remember, this is a disease. Disease like diabetes is heterogeneous. Some people start the set point at 13 and they just keep going up until 80 years of age, if they even survive to 80. Some people only start perimenopause. I don't know why. Some people start 21 years of age. Precipitated by a change in lifestyle, they started working, they're stressed, whatever. So then there's that set point. Once you have that set point, remember that homeostatic state, which you don't have to think about it. You keep that weight. Everything in you, your food preference, your choice of food, your choice of activities. I'm not talking about exercise. I'm talking about physical activity from morning until night. What you like to eat, how you deal with stress, what's your reward system, what's your family, everything there wants to keep that weight. The minute you go down 5 kilograms, it fires in your satiety, everything, to claw back that weight. And the more restrictive you do your diet, for example, if you start cutting all carbohydrates is 70%. It's the main food group. And you cut it all off. Your body craves carbohydrates. Basically, you're setting up yourself up for failure. Worse still, now you do intermittent fasting. You do 1 meal a day with 0 carbs. Just saying. How are you going to, you can survive, you will lose weight because your input is less than your output. But your body and your 5 million year old defense mechanism wants that weight back. And your body also feels that it doesn't have enough carbohydrate. Your craving comes. Craving. I see my patients 24/7. What discipline are you talking about? How do you fight this? If you look at a 40-kilogram woman, 80 years old, She likes vegetables. Don't ask me why, she just likes vegetables. 1 kilogram of vegetables is 100 calories. 5 potato chips is 100 calories. You talk about calories. She's effortless at 40 kilograms. So now, why is it difficult to lose weight? It's not difficult to lose weight. If you crash your diet, you can lose weight. What's difficult is to maintain that weight. It will always go back in general. If you look at all the data, whether it's semaglutide, whether it was the look ahead trial, the intensive lifestyle, it will claw back. Even bariatric, some of them would claw back to even 5% or that's failure. So that's why it's difficult to do it, because you have to know that it's a disease. Doing it yourself, difficult. We're not talking about outliers. We're talking about in general. So I told you a long story for why is it difficult. I hope that was understandable.
That's perfect. We'll come back to your second question later. But Dr. Nitin, continuing with this, now maybe too much of leptin resistance, or that's the satiety hormone, or too much of ghrelin release, that's the hunger hormone. That's what's happening. That's what Dr. Vivian is telling us. If you go on a crash diet, you stop carbs, you go on a one meal a day diet, the ghrelin will kick in sooner or later, and then you'll have to eat more. We explain this to our patients with an analogy of the difference between speed and velocity. So speaking of speed and velocity, does semaglutide have good speed, or does it have good velocity as well in terms of reducing weight and managing diabetes, managing glucose levels in persons with diabetes?
I would say yes, it would have both speed and velocity, because not only does the effect that I've shown in terms of the A1C and weight reduction happens pretty much fast as well. And before the next follow-up, when you get to see the reports, often you are pleasantly surprised that many of your so-called out-of-range values are bang on within normal range, within 4 to 6 weeks, as soon as that. So I would say yes for both speed and velocity.
And Dr. Unni, you've been working in public health as well now for the past many years. So how do we get these messages across? The message of optimization of weight, not only as a target in itself, but also as a means of preventing diabetes and means of preventing the complications of diabetes. Is the public willing to listen? Are we willing to speak out? How is our communication like as of today in India?
I think one of the areas where good communication is required in obesity is in childhood obesity, because that is the area where we can make a maximum impact. So several years ago, we ran a pilot project in school. We gave children a PowerPoint presentation, and before and after that, we gave them voting pads and did a pre-test and post-test on common foods and what is healthy, what is not healthy, what is a carb, what is a protein. And we found that just a simple 30-minute class is enough to inculcate certain key messages. And starting with the children is also important, because when the child goes home and tells their parents, see, my teacher told me this. Well, number one, if the father or mother tells, the teacher telling has a greater impact. Second, when the teacher has told a child to do that, that might be a good incentive for the father and mother and other family members to also, modify their diet and exercise. So I think prevention of childhood obesity, and that might be, in the long run, that might give bigger bang for the buck that people are willing to spend on obesity prevention at the public health level, because that's a generation that is going to grow older, and then presumably, if you don't tackle them, get type 2 diabetes and the other complications.
That's a nice idea, Dr. Vivian. In order to communicate with the entire society, with the entire community or the entire family, you focus on the children. You communicate to them and you communicate through them. Is that right, Dr. Unni?
Yeah, I mean, just a thought.
Yeah. So, Dr. Vivian, any other ideas? Singapore is also known not only in the Asia Pacific region, but across the world as a leader in public health. What kind of communication messages are going on in your country regarding prevention of obesity, regarding the upstream approach to diabetes management and prevention?
So what we did a lot of very early in the 1980s, I think, was that we had a tough program. when we went to the primary schools, and what they did was that they single out, well, rightly or wrongly, the ones who were obese. And then they put them through this program, which exercise and education. And we had some modest weight loss with regards to that. We stopped also for the children, aimed at the children, which I totally agree with Dr. Uni. We should aim at the children because the upstream effects will be terrible. The downstream effects are terrible otherwise. We also went to the tuck shops and they stopped them from selling snacks, sugaring drinks, sugar sweetened beverages. The other one that they did was they stopped advertising recently that to children. So they couldn't target the children at all. They stopped, sugar sweetened beverages and stuff like that from advertising. So things like Milo. We used to have Milo banners when I was in school, but we don't have that anymore. We won't have trucks coming in to give you Milo. So that ad would be targeted at the children. Now, at the community level, we have lots. We would have incentives given to the hawkers, the stores, the food sellers, with regard to incentives to decrease fats, decrease sugar. We have the labeling systems with regards to ABC, which is healthy, which is low sweet, low sugar and stuff. So we have that thing. And to even aid support to, charity and stuff as to how to donate, every single pathway that we do. And on top of that, physical activity as well, parks. We have park connectors, we have park making sure that about 15 years from now, we should be within, I think, about 10 or 20 minutes, 10 minutes walk or 400 meters from every park so that we could physically exercise or have activity. Because if not, Singapore is really hot and really small. They're difficult.
When you say of heat, many things come to mind. So, Dr. Nitin, we speak about diet, we speak about exercise. Dr. Unni has spoken about lifestyle management. But the WHO recommendations for physical activity, now they are very well thought out. It's good intention. But in a hot and humid country like India, is it possible for every Indian citizen to do that physical activity? What are some suggestions? What would be a pragmatic way of ensuring that you get adequate physical activity in the hot summer months without getting into other heat-related problems?
I think that's a very important question, sir. Thank you for asking that. Yes, I think it is sometimes difficult to do very strenuous exercise in hot climates. And 4 or 5 things which can be encouraged for our population, for the patients who come and see us for management of obesity. And I think the first thing would be to try and reduce the sedentary time for all the people who are, in their offices or working or with the computer. So every hour, if they are able to get up for 5 minutes and stretch out, that adds up to at least 25 to 30 minutes of additional physical activity per day. Obviously, if they can stand and not sit and do their work for many hours, that is also very, very helpful. So the first important point here would be to reduce the sedentary time. Second thing would be to make whatever exercise they do much more enjoyable. And I had this patient this morning, and when I told her last OPD that she likes to listen to music, but she doesn't like to go for walking. So I said, why not you listen to 10 songs when you go to the your physical activity that you do, be it within the house, be it within, but you label it to something that the patient tends to like or to do it rather than add on additional burden. But yes, in the heat time, other exercises like doing swimming or indoor methods of doing exercise, and COVID taught us a lot of that during small confined areas, how we could still do physical activity. Yes, sometimes people who are overweight or obese, they are finding it difficult because of osteoarthritis to do a lot of walking again. And again, freehand exercises are something that can be done. Cycling, stationary cycling, again, can be done away from the sun. So there are some tips that can be offered to people who don't want to go out the sun and do strenuous exercise.
Dr. Vivian, we have a very famous Hindi song. It comes from an old advertisement. It's Har ek friend, each and every friend, Har ek friend, zaruri hota hai. Each and every friend is important in life. And similarly, Dr. Unni, har ek step, har ek move and shake, every move, every shake of the body, does it contribute to weight loss? Or is it that I actually have to go to the gym in order to lose weight?
Well, when you mentioned STEP, I was thinking of the STEP 1 trial, which I was a principal investigator of, which did injection semaglutide. Well, keeping that aside, I think every step counts, but people tell me that, I've been walking and walking and walking and running and also trying to lose weight, but I haven't lost weight. And meta-analyses have shown that the average mean weight loss from exercise is about 2 kilos. So exercise is not a great way to lose weight, but we must tell our patients to take that extra step to have as many steps as possible, because exercise is a magic pill for glucose control, lipid control, weight, reducing the weight variability and maintaining the weight, hypertension, etc. So I think we must tell our patients to exercise, but change the goalpost a little from weight to health. Once we change that goalpost, I think our patients will be much fitter. That itself contributes to something. And of course, diet also has to be looked at, because as they say, one can't outrun a bad diet. So exercise isn't the only thing. You'll have to complement it with diet as well.
Sanjay, Dr.
Yes.
Sanjay, can I add with that? Because I was very interested in you saying that every movement counts. As I'm sitting down here for that 2-hour session now, I don't know how much calories I've used, given I'm fidgeting under the table, and you can't see my leg shaking. So that's one part of it. Fidgeters, people who are fidgeters, they actually have documented that they actually lose more calories. And they could even unconsciously lose up to 600 calories a day. 600 calories a day is equivalent to that of 6 miles of jogging. That's how much it is when they start eating more. So they unconsciously use more at the same time. You were mentioning about, why is it difficult to lose weight sometimes? I thought it was more difficult to maintain, but one of the reasons why it's difficult to lose weight is because of the perception of food that they eat, how much they think that they eat. And it's the gross estimation error. And again, studies have shown it could be as much as 50% estimation error. You think you're eating 1,000, but you're actually eating 2,000. It doesn't help that if you do exercise, which then fires your hunger genes, hormone, and you get more hungry, and then you eat more, and you overestimate your exercise, and you underestimate how much you eat. So people actually put on weight with exercise. So just a 2 cents worth of that.
Dr. Vivian, that happens in cricket as well. So in these one-day matches, the team that bats second should have a fair idea of their targets. How many runs they have to score in the first 25 overs. If it's going to be a rain curtailed match, at what speed they have to score. And sometimes they make mistakes. And then at times you actually find that the better team has lost the match because they couldn't calculate properly, or because their coach couldn't help them calculate properly. So I guess that calls for a need for a coach as well. You spoke of fidgeting, madam. And Dr. Nitin, we always speak of balanced diet, a diversified diet, but we never speak of balanced physical activity or diversity in physical activity and exercise. Actually, apart from one paper by you, when I go and read the net, when they speak of diversity in sports, what they're talking about is inclusion of minorities, marginalized communities, various genders in sports. But you've spoken about physical activity diversity or exercise diversity in a totally different manner. How does that help us? Especially, let's say you're taking semaglutide, and then your patient is taking semaglutide. She comes back to you and says, "Doctor, the first 3 to 6 months were fine. The speed was good, the velocity was good, but now I'm stuck." So then what can you talk about using different muscle groups in different ways?
Definitely, sir. So I think the important part of exercise that is to be emphasized is that we don't start all of it on day one together. It is a stepwise process, starting from flexibility and then going on gradually to balance training, then to aerobics, and finally to resistance exercise. And each of them definitely have a specific role not only for glycemic control, but for weight management as well. As has already been mentioned, I would definitely reiterate that losing weight sometimes can be challenging. Just keeping that formula in mind that you need to lose 7,000 calories to actually lose 1 kg of weight. So that's how the quantum of exercise is required for weight loss, which is much easier if you couple it with a diet and then use weight exercise for weight maintenance. But yes, your question about how we have to fool the set point. Once we've lost weight with the help of one modality, we have to add on another modality, and that will help us get the additional weight loss as a step. So in my practice, I would on day one only talk about diet and exercise to my patients. They would, if they follow that, they would lose 3 or 4 kgs, and they come back at 3 months and then say, doctor, we are not losing any more. We're doing everything what you said, probably even more, but still the weight scale is not moving. And that's a time when you add another modality, maybe something like semaglutide or meal replacement, you lose another 4 to 5 kgs, and again the set point reaches. And I think then that's another time to intensify with another modality. So that's how we fool the set point. But one modality will definitely get stuck at some point or the other.
Thank you. That makes sense. And also we should counsel our patients to not just walk or not just cycle. Let's say I begin walking every day. Then my walking muscles become so efficient, they stop burning fuel. And I'm walking on only one style. So either I can start Nordic walking, or I can walk maybe the Jhumar style. That is one of our dances from North India, Dr. Vivian. Or I can walk like I can do duck walking. So to use different muscles of the body, of the lower limbs while walking. Another thing would be to do different exercises so that you use each and every muscle group of each and every part of the body and ensure that full range of movement is offered to the muscles. So that will, and every day, every week you exercise different group of muscles which are not attuned to exercise. So the efficiency is less and actually they end up burning more fuel. Dr. Unni, one last question for you. And this is, we've run out of electricity here in Karnal. This is one of the challenges that we have. But I think I'm, visible now. Adaptation is not bad. Dark adaptation. Okay. So, Dr. Unni, we have this concept of Alcoholics Anonymous in de-addiction psychiatry. Would it make sense to have a concept of barrow buddies? People living with obesity and overweight, of course, it's all overt obesity, overweight, working together to help each other out. Would that make sense? Have you tried anything like this in your center?
There are two angles to this. Before I say that, I must say that, when the current went out, your smile was still luminous in the dark. So thank you for smiling so much. So I think that there are two angles to it. In a very ideal society, there would be no fat shaming. And an obese person into aware that obesity is a chronic disease, not just eating less, eating more, and exercising less, but about the biology, the community, the society, the family, everybody, with a role to play. But that would be an ideal society. And because of the stigma, if people are not able to talk to each other about it and find solutions, then I think an obesity barrow buddies could be a good idea. But the other side of that would be that it might well be about sympathizing and understanding each other than about actually getting to lose weight. So I think barrow buddies is fine, but there should be a couple of people in the group who are also who are barrow buddies who've reversed their obesity and or got to normal weight. So a good mix of people who have come out of obesity and people suffering from obesity, that would be better. And that's what Alcoholics Anonymous is also. The only thing is that it's alcohol. So I think these two angles, but in a perfect society, I'd like to see obese people integrated fully into general life and be able to talk about it openly.
That makes a lot of sense, actually. So you should have barrow buddies and you should also avoid barrow bullying. And there should be no social stigma related to obesity. We have with us logged in Dr. Arun Prabhakar and Dr. Umanath. Thank you for your insightful questions, sir. We have a few more questions. Dr. Nitin, if you could take one question. When you put patients on semaglutide, sometimes they have transient nausea, transient vomiting. How can you minimize that?
Correct. So I think first thing is counseling the patient correctly so that you can tell them that this at times could be transient and go away. Yes, making sure that they follow the correct method of taking the tablet, empty stomach, minimal water, half an hour gap. We can use antacids to reduce these symptoms at times, and most patients would be able to tolerate. If the symptoms are very severe, we can step down the dose and try. And still, if they have very severe symptoms, give a small drug holiday and restart once the patient gets better. So these would be 4 or 5 methods how we can reduce these symptoms. But by and large, the confidence that I've got of using these small doses as compared to 25 and 50 that we've used, I think this is quite a mosquito dose, in fact.
So you see, when you have in pregnancy, when you have early morning sickness, the etiopathogenesis for that is that the progesterone levels are higher in the morning. Now, what happens to progesterone in men? Honestly, I'm not aware. And Dr. Vivian, in India, our go-to person for questions like this is Dr. Uni Krishnan. All these out of the box and below the belt questions, he's the only one who tackles. But still, what you will see in some patients is if you give them semaglutide early morning, they will complain more. But they will say, I'm so nauseous. I just don't feel like having breakfast in the morning. My breakfast happens at 12 noon or at 1 p.m. So that's fine. By that time, the endogenous progesterone, whether your patient is male or female or anything else, that would have actually gone down. And then you can change the timing of semaglutide. So suppose a person is complaining or you're in a difficult situation on a sticky wicket, let them have a cup of black tea in the morning, maybe a few nuts. And when they're about to have their proper breakfast at noon or around that time, you can give semaglutide half an hour prior to that. At that time, there will be no progesterone. And actually, you will find that the acceptance of the drug, the tolerability goes up markedly. So try that in some of your patients and see what happens. Madam, one question for you. In India, we have only oral semaglutide, but we've heard that in Singapore, you have subcutaneous semaglutide as well.
Yes. So
how do you choose? Which drug do you choose in which type of patient?
I'll be very honest, because by the time they come to me tertiary, right, they would have failed primary. So you'll be dealing with intractable cases like, true obesity. So in such a situation, I think injectables come in very handy. I know that Nitin is doing his trial of 25 and 50. I think I read the phase 2 studies, and which showed that they did pretty well, in the 50 milligrams. But we don't have 50 milligrams, but we have Wegovy. Not Wegovy. We have Ozempic 1 milligram, but we can use it in the Wegovy amount. So I think it would be. It's all about. It's a dose thingy. So if you use Ozempic semaglutide, which is 14 milligrams orally, that's equivalent of 1 milligrams injectable. So therefore, it might be on par with each other unless you cannot take it orally or the absorption is bad. So then the data I see is, with my patients, they are on par if you do 14 milligrams or if you go 1 milligram. But if you do 14 milligrams, which is the 1 milligram injectable equivalent, it would not equate. You can't get 2.4 milligrams. It won't get there. So I guess I would use it. I could start with Rybelsus, the oral, and then I would go on then to the injectables and further upwards when I find that they need more. And it really depends on the patient. If my patient comes with a BMI of 40, Rybelsus ain't going to cut it, because the oral just can't. If it's 50 milligrams, sure, it will, because that would be touted to be equivalent. I don't know the data ultimately to be equivalent to that of a subcutaneous 2.4. Yeah. So I think that's where we are moving. And especially I think in India, it would be I know it's Rybelsus only, but in India, I think it would be very helpful because there's a group of people where the BMI is not that high. You have a wide group of people, 23, 25. I think it would do very well with Rybelsus then. And culturally, they don't accept injectables so much. It takes a lot of time to counsel them otherwise. So it's very good approach to start with an oral semaglutide first. and then to move up, and then slowly progress if you find that there's plateau.
Yeah.
If the weight's not coming down, then you want to progress upwards. You want to try injectable first, if they come, when they come, and then move further.
That makes sense. And that also is the same thought process that Dr. Nitin shared with us when he spoke about fooling the metabolic set point by adding one intervention at a time, by adding one exercise or one dietary therapy at a time. So if you do everything on day one, first of all, it might rebound because you end up with side effects and then you can't manage them. And then the second thing is, what do you do about velocity? What do you do 3 or 6 months down the line? So it's good to go stepwise. We've been speaking with each other, Dr. Vivian, Dr. Uni, Dr. Nitin, for so long, and it feels as if we've just begun. We've barely scratched the surface. But it's time for other things as well now. More, calorigenic and obesogenic things to do after this webinar. And I'm also told one of our close friends is Dr. Madhur Verma. He's an expert in community medicine. So he warns us that if you sit on a chair for more than 20 minutes, that is equivalent to smoking one cigarette in terms of CV risk. So if we could conclude, I'd like to invite Dr. Kingshuk. But before that, Dr. Uni Krishnan, just one line from you. How do we communicate the benefits of good health to our community? Instead of talking about treating disease, how do we talk about preventing disease?
I think it is time that we doctors become good communicators as well. And just like, you have so many alternative medicine people who peddle, unscientific therapies, unscientific diets, and unscientific information, who are good communicators. We should present the best scientific evidence while being good communicators. So good epithets like what you mentioned just now, sitting is the new smoking, sugar is a new cholesterol, don't drink calories, sugar sweetened beverage, just don't drink calories, some simple messages like that. I think we should bring out such messages, and those will catch the public's attention, and therefore we can try to make a meaningful change. I think it's a long way off because doctors are traditionally shy to venture into media and education and awareness. But I hope the day will come when we are also aggressive enough to spread the right information.
Dr. Vivian, it's been great having you with us. We always learn so much from your insights. Final comments for our audience. People logged in from across the country, more than 500 people.
Stay positive. Weight is not your fault. Please come and approach us. We will help you all we can.
That is a very optimistic message. Thank you, madam. Dr. Nitin, in Indian philosophy, it is said that in our poetry, it is said that the journey has its own charm. The destination, of course, has its own. So here the destination is weight loss, but the journey is going towards weight loss. Also, in our philosophy, it is said that you have control only over what you do, over your actions. You do not have control over the outcomes. How do you synthesize all these together? What message would you want to give to your patients when it comes to choosing the right therapy for managing both weight and diabetes together?
Correct. I think having the right coach is very important, who makes your journey and destination both beautiful. And that is, so you do your bit, you understand from the right person rather than from all the information that comes from different sources, which may or may not be correct. So I think choosing your friendly neighborhood endocrinologist to try and guide you through this process will make your journey, destination, actions, and results, everything good.
What I would like to add is, Dr. Kingshuk, with your permission, is that if you focus only on weight, only on waist, only on body mass index, it's a wrong strategy. How can you encapsulate the entire gamut of health? The definition of health is something that is still being debated. And even a person like me, we are able to find fault in the WHO definition. They do not speak about sustainable health. So like you can go on a water-only diet for 3 weeks, for example. For 3 weeks, you will be healthy. But what will happen in the 4th week? The WHO definition does not cover that. They don't use the word sustainable in good health. So it's not so much about just BMI or just body weight or waist circumference. It's about so many numbers. Some of them we can calculate. Others we can just get a feeling, quality of life, happiness. We give numbers to them, but it's more of a feeling. They are more subjective. If you are able to explain this to the patient, that there are multiple things associated with health and happiness, and our work is to choose the right medication, the right lifestyle. So let's choose sensible lifestyle, and let's choose evidence-based medication. And let's try to cover as many targets as possible, which will include weight, anthropometry, which will include glucose control, and will include other things as well. For example, cardiovascular risk. Then we are on the right track. And let us just remain on the right track with the help of a coach, a doctor, with the help of barrow buddies. If we follow that process properly, then I think the results will come automatically, and they will come in terms of health and happiness. If we are able to convey this to our patient, I think life will become happier for all of us, for not only for patients and people, but also for the doctors who are treating them, for the endocrinologists. With this, on my behalf and on behalf of Dr. Unnikrishnan, Dr. Vivian Lim, Professor Nitin Kapoor, I would like to thank everyone for having been with us. But for final words, we look up to Dr. Kingshuk. Dr. Kingshuk, how are you able to maintain your weight?
Thank you so much, sir. Before I say that, sir, I think today we have witnessed one of the excellent panel discussions, which have been nothing short of extraordinary. And I think we have close to 550 audience still into the meeting, and we are close to 2 hours now, which is a testament to the brilliance and the extraordinary discussion that we had in the last 40 minutes, and that each one of you brings to the table. I think how I maintain weight, I'm probably more active, being more studying and more being in hearing to the exchange of the ideas that you and along with Dr. Unni, Dr. Lim and Dr. Nitin Kapoor has given, and we have always been witnessing to the exchange of the ideas by which probably we forge the new pathway and try to inculcate them in our lifestyle, sir. I think, but I do understand Dr. Unni has another meeting where he has traveled physically and still has joined us. But as we draw end to this remarkable event for the last 2 hours, I think we had witnessed some excellent discussions, and it has been learning for me. I think I learned many things new today, and I think I have made a note of it. I will go back and read the papers, I think, by Dr. Kapoor and Dr. Unni, Dr. Lim, all over, which are mentioned during the discussion, so that we can expand our knowledge. But I would like to express and extend on the behalf of Novo Nordisk our heartfelt gratitude to you, Carla sir, for excellently moderating the panel discussion, and to Dr. A.G. Unnikrishnan sir, Dr. Vivian Lin, who has joined us from Singapore, and I think they are close to midnight now, but still, ma'am, you are there with us, and Dr. Nitin Kapoor, I think, for sharing your knowledge and expertise with all of us. And I think we are immensely grateful, and all the audience, I think, for their unwavering commitment and to the pursuit of knowledge. Actually, all of them are with us, I think, for the last 2 hours. So thank you so much. And today, I think we leave here with a sense of accomplishment, inspired by all the possibilities and the discussions that lie ahead. I think we have no doubt that all these discussions that have generated will impact many lives of the patients with type 2 diabetes and shaping up a healthy lifestyle for all of us. Thank you once again, sir, for all your invaluable contributions, not only to this meeting, but all the scientific discoveries and the ideas you all have been contributing throughout. We have been your students and will be your students for the years to come, because we learned a lot from you. Thank you so much once again to all our esteemed faculty, and also to all the audience for being with us. Almost we are close to 2 hours. So thank you so much once again, sir. I wish you all a happy weekend ahead, and good night from all of us. Thank you so much.
Good night.
Good night. Goodbye.